Greetings all, Shelby Rainey here. Today I'll be talking with you about differentiation of primary and secondary dengue infection through immunoglobulin M and immunoglobulin G. Dengue infection is caused by the dengue virus, which is a positive single-strand RNA virus that's a member of the Flaviviridae family, and it has 4 distinct serotypes, so DNV 1 through 4. Now this virus infects and replicates within the innate immune system, so dendritic cells, macrophages, and monocytes and lymphocytes are targeted by this virus, and it's actually endemic to Central America, South America, Africa, Asia, and the Oceania region does receive epidemics within it annually, so parts of northern Australia, Papua New Guinea, and New Caledonia Island are at risk of developing cases of dengue. Dengue infection occurs when you're bitten by one of the 2 vectors for this virus, so either an A. albopictus mosquito or an A. aegyptis mosquito. Having the virus in your body will result in either a primary infection or a secondary infection. Primary infection is where you're infected for the first time in your life and you end up with dengue fever. Now this fever is characterized by its biphase nature in that you'll have this fever, it will break, return again, and break again over a 1 to 2 day period. You'll also have low blood platelet count, low white blood cell count, increased size of your lymph nodes, a headache, eye pain, rash, and itching. And this, once you're recovered from this dengue fever, you will be immune to that specific serotype of dengue for the rest of your life. However, if you ever become infected with a different serotype of dengue, you'll end up with what is known as secondary infection, and that is a lot worse. You'll end up with what is known as dengue hemorrhagic fever, and according to the World Health Organization, they characterize this fever as being acute and continuous over a 2 to 7 day period with hemorrhaging associated with low blood platelet count, as well as hemo concentration, so a thickening of the blood. Now, this hemorrhaging is caused by increased vascular permeability due to your immune system releasing cytokines that damage your vascular walls. Having too great of a vascular permeability, though, will result in dengue shock syndrome, and this is a form of hypervolemic shock that causes reduced peripheral perfusion, so blood flow to your extremities, leading to tissue injury and multi-organ failure. This is where you get the bleeding coming from your mouth and nose, bleeding of your gastrointestinal system, and this is usually where people die a lot. As it currently stands, the treatment options for dengue is antivirals, but mainly it's tepid sponging, so applying a cold compress to the body to help bring down the fever, as well as providing antipyretics, so medicines that will bring down the fever and reduce the pain for the patient. Also, as of May 27th of last year, the FDA did approve a vaccine for dengue. It's called Dengue-Vaxia. It's currently only administered to people who have had previous infections, so primary infection, and are currently living in endemic areas. Now, as I said earlier, Asia is endemic with the dengue virus, and that includes the subcontinent of India. India itself has been endemic with this disease since the 1960s, with annual outbreaks occurring with all 4 serotypes. Now, this is also one of the countries most affected by this disease, with 5.2 million people being infected with the dengue virus back in 2019. Now, the researchers involved in this study went to 3 research hospitals in the city of Gurgaon in the North India state of Haryana, and they wanted to look at the best immunoglobulin M and immunoglobulin G ratio in order to differentiate between primary and secondary dengue in their native population within the first 3 days of symptom onset. Now, it is important to differentiate between primary and secondary dengue early in the disease in order to provide an accurate prognosis to the patient in order to decide if the patient should be admitted into the hospital and undergo close monitoring, or if they should stay at home and be managed by their loved ones. This is especially important during epidemics and outbreaks when those hospitals will be full of patients and early triage is a necessity. Additionally, the researchers used enzyme-linked immunosorbent assay-based tests in order to differentiate because they are cheaper and more easily available in poor and rural areas. In order to do this, the researchers would line a 96-well plate with capture antibody. They would then add the serum from the patient, so their blood, which will contain either immunoglobulin M, IgM, or immunoglobulin G, IgG, and that will bind to the capture antibody. From there, the detection antibody will bind to the IgG or IgM, and then the enzyme horseradish peroxidase will bind to the detection antibody. Then the researchers would add a substrate which would interact with the enzyme and form a color change that can be detected under a plate reader. This color change detection would then be used in order to figure out the IgM and IgG ratio. Now, in order to determine whether or not somebody was actually infected with the Dengue virus, the researchers had the patient's blood undergo SD Bioline Dengue Duo Rapid Test Kit, which is a qualitative detection of NS1, which is a viral antigen produced by the dengue virus, as well as a detection of IgM and IgG antibodies. Now, these antibodies were then used to classify the patients as having either primary or secondary infection. Now, the researchers defined primary infection as having negative IgM or negative IgG antibodies, or positive IgM with negative IgG antibodies within the first 3 days of symptom onset. Secondary infection was defined as having negative IgM with positive IgG, or positive IgM with positive IgG antibodies within the first 3 days of symptom onset. Now, dengue IgM and IgG index measurement was determined through the use of Focus Diagnostics Dengue Virus IgM and IgG Capture DX Select, which are nothing more than indirect ELISA tests, the same ELISA test that I had described to you in the previous slide. Now, the researchers were able to determine that if the test had an index greater than 1, then it was presumptive for the presence of IgM or IgG antibody that was specifically for dengue virus. Now, the ratio of IgM to IgG was calculated by dividing the IgG index value into the IgM index value for each sample. Now, when comparing the IgG to IgM ratios for the diagnosis of secondary dengue fever, the researchers were able to conclude that a 1.10 IgG to IgM ratio was the best out of all the ratios that they looked at over a 5-day infection period, due to it having a sensitivity of 100%, a specificity of 97.4%, and a 38.46 positive likelihood ratio. Now, this is important, again, because if we can differentiate between primary and secondary fast enough, then we'll be able to get that person into the hospital so that they can undergo treatment for hemorrhagic fever while sending the person who does not have hemorrhagic fever home to be with their family to have self-care at home. Now, in the discussion section of the research article, the researchers were able to state that a mean IgM index tested on day 2 of illness was found to be higher in primary cases than in secondary cases, and a mean IgG index tested on day 2 of infection was found to be 4 times higher in secondary cases than in primary cases. All this combines together to state that obtaining an IgG to IgM ratio of 1.10 on day 2 of illness is the best cutoff value for differentiating secondary from primary dengue infection. The one limitation of this research, though, was that this method was not able to differentiate between secondary, tertiary, or quaternary infection. The researchers would still have to use real-time PCR in order to tell the difference between these 3 other forms of infection. However, this method was able to differentiate between primary and non-primary dengue infection. In conclusion, early IgG to IgM ratio can become an important player for differentiating secondary infection from primary infection. Also, obtaining IgG to IgM ratio on day 2 of illness with a ratio of 1.10 is still the best cutoff value for secondary infection detection. Finally, an IgG to IgM ratio can be used in some situations, so a clinical setting, as an additional tool for patient screening in addition to the traditional clinical warning signs of dengue. Now, again, this would be useful during an outbreak or an epidemic wherein the hospital staff needs to determine who should be admitted into the hospital and undergo close monitoring and who could go home and recover from the primary infection. These are the references that I used for this presentation. And now I want to thank you all very much for listening, and I will take any questions that you have.